So we look forward to welcoming you to those events. Please do continue to monitor the website. We do have other events that we have arranged. They will be appearing on the website in the next few days. You can see on the left-hand side of the screen as well, if you haven't already signed up to our monthly newsletter, you can, there is a link on the left-hand side that allows you to subscribe to our mailing list. And through this subscription, you'll receive updates of upcoming events and our monthly newsletter, which outlines the events that we have coming up. Following today's session, many of you will want to claim your CPD points. So the way to do that is on the website as well. So you'll be able to, following the event today, the CPD evaluation link will become live. You'll complete the evaluation and a certificate will be generated for you. So please, today after the event, don't forget to click on the evaluation and complete the questions. In the next few weeks, we'll be sending out a further survey to you to get an idea from yourselves about how you would like CPD delivered. So would you prefer a face-to-face, considering going back to face-to-face, or continue these online webinars? We want some ideas about scheduling, timing, which days of the week, how long do you want the CPD session? So we'll be asking you a few questions to take some feedback from you. At this point as well, I'd like to welcome our viewers on YouTube. So we've opened up YouTube complimentary access for all of our events, and we'll be monitoring the chat throughout. So please participate through the chat, both on WebEx and on YouTube. And we'll be putting your questions and your comments to the speakers throughout today's event. So just a brief outline of today's event. We'll have Dr. Susu, who will introduce the topic. Then Dr. Khalid will be presenting. And I think, Dr. Khalid, you're happy to take questions through your presentation. Would that be okay?
Yes, should be fine.
Thank you. And then we'll be finishing off with Q&As, and then there'll be an assessment at the end, some MCQs for you to respond to. So without further ado, I will now hand the presenter ball over to Dr. Susu. You'll be able to...
Thank you very much, Dr. Zakaria. Assalamu alaikum, everyone. We welcome you to, can I share? It seems not active on my end. Okay. I want to share my slides, and again, I welcome you all to this very first session for our CPD from Qatar University. As Dr. Zakaria mentioned, today we're gonna take you through a seminar or a webinar on the value and the importance of vaccines in protecting the community. And briefly, will be presented in segments, and we'll have the floor open for question and answer and discussion. So would like all of you to be engaged with us through the evening. So why do we need to learn about vaccine and the values of vaccine? Just to give you an example of the overall mortality rates for all causes since 100 years ago till now, still at the same level, right? But now the mortality rate because of infectious diseases had declined dramatically. And if you ask yourself why, it's because the intervention with vaccines that prevented many infections that used to claim lives. And here I would like to show you the parallel 100 years ago when we had the Spanish flu in 1918, the peak in the mortality that occurred because of the infectious disease, and think of today and the devastating COVID-19 pandemic that we have right now and the toll of mortality. We're lucky to have the vaccine here, and that's the core of our presentation. So vaccines has the power to eliminate infectious diseases. Smallpox actually was eliminated by the use of vaccine and vaccination. But when we talk about community protection, we're talking about mass vaccination, vaccinating many people. Like the more we cover in the population, the less burden of disease there will be. So the number of infections would be much, much reduced. And actually, if we spend $1 on vaccination programs, any government would save $10 in the cost of treating those infections. So vaccines are the most cost-effective intervention for preventing infections. My screen isn't moving. Okay, I'll give you a quick example how vaccines work. When you think of a very common infection among children, for example, and adults, caused by bacteria called Streptococcus pneumoniae, and causes variety of infections from conjunctivitis to otitis to pneumonia to septicemia, etc. This bacteria possesses a very hard shell made of sugar called capsular polysaccharides. When the vaccine was introduced based on these capsular polysaccharides, you could see the incidence of invasive disease had declined dramatically and continued to decline until this very day. So that shows how the power of vaccine limit the spread of disease. So not only protecting the children, you're protecting their parents, their caregivers. You send them to daycare, you protect the people around them. So that's what we call extending the effect to protecting the community as well. But very brief note about how vaccines work. Vaccines are not infectious. They prevent infectious diseases, but they mimic disease in a way that they stimulate your innate immune system to respond, because your innate immune system would see the vaccine antigen as invader or infection and activate the armament to respond and communicate with your adaptive immune system, your B and T lymphocytes, and that would generate humoral immunity, meaning antibodies that will recognize the pathogen and protect you, or cell-mediated immunity with memory that also recognize the antigen. So that's how vaccines work, mimic infection. And some vaccines, and actually many vaccines, they require a booster. So when you ask, why do we need boosters? It's for enhancing the immunological response, for better protection. When you are exposed to infection or getting a vaccine, you will have a primary immune response as seen here. You'll have enough antibodies and enough immunity to protect you, but it's on a smaller magnitude for a shorter time. Once you give the booster dose, the body already had seen the antigen, so it amplifies dramatically the antibody response and the adaptive immune cells, T cells and memory cells, and that gives you much longer protection. That's why we use boosters. We have various types of vaccines that are available and licensed currently. The live attenuated, meaning the pathogen is live but too weak to cause infection, so that's why it's attenuated. Or it could be killed, very inactive. It will not cause disease at all or replicate in the host. Toxoids, when we take the toxin from certain bacteria and inactivate it and convert it to a vaccine, so the immune system would recognize it, and when you get exposed to the pathogen toxin, it will be neutralized by the antibodies. Conjugated vaccines, when you have antigens like sugars, like capsular polysaccharides, they need protein carrier to hold them into a better immune response, make them T cell dependent antigens. So we conjugate the sugar vaccines or subunit vaccines. But now we have a new form of vaccines that you all received, I assume. It's the mRNA vaccine. It's the COVID new type of vaccine, the COVID mRNA vaccine. And in this technology, they, for the first time, succeeded to use the messenger RNA, this genetic code for the spike protein of the coronavirus, and put it in a protective nanoparticle so it will not degrade and break, because RNA is very fragile and sensitive. Once injected into the skin, the immune cells will take these nanoparticles and drain it and present it into the lymph node, where the antigen, the protein being transcribed, presented to your immune cells, and you will end up having antibodies and T-cell responses. That's mRNA vaccines work similar to other vaccines and gives really strong responses. Vaccines are delivered in different routes, could be through the skin, could be intranasal, could be oral, and also in the near future, it will be in form of micro needle skin patch transdermal vaccination. So in a nutshell, this is what vaccines do, and the concept of how they, how they induce protection and immunity. Now, I'd like to give the floor to Dr. Khalid Al-Awad to share his slides and give his lecture. Meanwhile, I'd like to properly introduce Dr. Khalid to you. He's my colleague at the PHCC. Like, we've been collaborating for some time now. Dr. Khalid is a medical doctor and public health consultant. He has 20 years of international experience in the field of public health. He worked on both developing and developed countries. Currently, he works as health protection manager at the PHCC in Qatar, and he plays a role in developing and shaping and assuring the health protection function in primary healthcare corporation. Recently, he has been appointed as chairperson for the Antimicrobial Resistance Stewardship Committee that execute National Action Plan to control antimicrobial resistance. Dr. Khalid also chaired for Infection Prevention Control Committee and oversees the IPC program at PHCC. Dr. Khalid is a member of many national and international public health committees, and we thank you very much for joining us today. Dr. Khalid, the floor is yours.
Thank you very much. Thank you, Dr. Susu. Thank you, Dr. Zakaria. Assalamu alaikum wa rahmatullah. Good afternoon, everybody. Good evening right now. I really want to thank Qatar University for this opportunity and for the collaborative work that's always have been there between education institution and service provider to make sure that we align all our health strategy together and to tackle whatever health problem and that we are facing here in Qatar. Today, as Dr. Susu started, we'll be speaking about vaccine preventable disease, the herd immunity, Qatar immunization program, and adverse reaction from immunization. Of course, I don't have any conflict of interest. I don't know why the...
Click on the side of the screen and try to move it.
I'm trying to do that, yes. Yes. Okay, so in this presentation, I will be speaking about, I'll explain the principle of vaccine and immunization. I will describe the evidence-based vaccine cost effectiveness and burden of vaccine preventable disease. Also, I will give very touch about vaccine development, outline vaccine hesitancy, current licensed vaccine in Qatar, and immunization schedule in Qatar. Also, our system for adverse event from immunization, and I will touch on the vaccination ethics and the travel clinic vaccination, travel clinics services that we are running in primary healthcare. So, importance of vaccines. I think Dr. Susu already have explained that vaccine is known that the most effective method to prevent the spread of infectious disease and one of the most cost-effective public health measures strategies that have been used to tackle infectious diseases. But with the time, and as Dr. Susu was mentioning, that the burden of infectious diseases is declining gradually, people tend to forget the importance of vaccination. So in my next slide, this one here, I'm just presenting photos for infectious diseases that right now we don't see or we are rarely see. And as Dr. Susu was mentioning, the smallpox is already eradicated totally. We don't have it. You can see the smallpox in the middle with devastating scarring and for the patients. Also polio. Polio, it's a disease with that can cause disabilities, and his symptoms vary from flu-like symptoms to life-threatening paralysis, and also can cause paralysis of the arm, legs, and muscles. and breathing muscles and can lead to death. Between 5 to 10% of people used to die from polio. Alhamdulillah, we don't see any polio cases here in Qatar. Also, tetanus, this neonatal tetanus specific, was a very deadly disease for children, and with a mortality rate about 70 to 100% mortality from the tetanus. As I said, smallpox is a terrible disease. On average, 3 out of 10 who contract smallpox usually died. And people who usually survive, they will have to live with the scars all their lives, and these scars will not disappear. And lastly, the measles, that alhamdulillah last year, we recorded 0 cases here in Qatar for measles, and hopefully this year also, as we are targeting to achieve elimination of measles in the state of Qatar. So all these diseases, this was before vaccination, and they have a different impact and burden on the health system and on the human life. But right now with vaccines, we don't see these diseases. So there is some important definition that we all need to agree about. So the first definition that everybody needs to know is vaccination coverage. We are hearing a lot about vaccination coverage. So what is vaccination coverage? It is the estimate percentage of people who have received specific vaccine. It's used to understand how well communities are protected from vaccine preventable disease. You will find that vaccination coverage is different from country to country. And this will have an impact of the spread of the infectious diseases. So, for example, you will see in some countries they will have more TB cases, or they will have more cases of measles, or they will have more cases of varicella from other countries. So these depend on the vaccination coverage inside that state. Also, community protection. We are hearing a lot about herd immunity, and Dr. Susu just touched about it. So community protection is community occurs when a vaccinated person block the chain of transmission, protecting under-vaccinated or unvaccinated susceptible community members by preventing exposure and limiting the spread of the pathogen through the community. And we always hear from WHO the global vaccine coverage, and it refers to proportion of war children who receive the recommended vaccine. And as long as the coverage will increase, as long as the disease will decrease. So this is very important to understand. Now for the herd immunity, and we have heard, many people used to talk about during this pandemic about herd immunity a lot. So herd immunity, usually when most of the population is immune to an infectious disease, this provides direct protection to those who not immune to the disease, who are typically communities' most vulnerable individuals. The question is, can I vaccinate everybody? No, I can't vaccinate everybody. So how can I protect the one that I can't vaccinate? Why I cannot vaccinate everybody? I will give an example. So we have some of the vaccines, like live-attenuated vaccine. We cannot give this live-attenuated vaccine for pregnant women. We cannot give the live-attenuated vaccine for people without immunocompromised. So how can I protect them if I cannot give them the vaccine? The only way is by achieving the herd immunity of that particular disease. So when everybody is vaccinated around these people that they cannot receive the vaccine, so by this they will be protected, and this is what we call the herd immunity. And I will give you an example. For example, the DTaP vaccine. So for example, if you had an anaphylactic shock, if you have allergy for the component of the vaccine of diphtheria, tetanus, or pertussis, you cannot receive the DTaP vaccine. If you have an anaphylactic shock before when you receive the vaccine, you cannot have the vaccine. If you have a seizure or another nervous system problem, you cannot receive it. If you have a Guillain-Barré syndrome, you cannot receive it. So for these people that cannot receive the vaccine, the only way to protect them is through herd immunity. Now, Dr. Susu just also touch about how communicable diseases have been decreased over time. And here I'm giving just an example of measles in the United States between 1962 to 2014, when they introduced the vaccine in 1963 or 1967. And you can see that the number of cases were very high. And since the introduction of the vaccine, the numbers start to decline slowly. And this is what we call in public health to control the infectious disease. So controlling it by reducing the number of the incidence or the new cases of the disease to reduce it to acceptable level. And this acceptable level can be, as you can see here, in 1970, they reached lower level, and then 1980, they reached a much lower level. And when reach like this level, we call it elimination, which we are trying to reach the disease with a 0 number. And after a while, as you can see in the 2000, there was elimination declared in the United States for measles. And after that, it was totally eliminated with 0 cases from local infection. When we say, by the way, elimination, we are talking about the local transmission. There is no local transmission inside the country or inside the geographical area. But still you can have imported cases, because with the travel, everybody travel anywhere, they still will have some cases of measles, but usually these cases should be established that they are imported cases and not from local transmission. And lastly, the last stage of the vaccine is, because some people will ask, are we using vaccine forever? You can see here from the measles, it needed from United States from 1960 until 2000, so they can eliminate measles. So sometimes it will need more years even. But in the end, you start with that, you start with the control, and then you eliminate, and lastly, it will be eradicated. And the only disease that we have been eradicated until now, that humanity have been eradicated, smallpox, which was eradicated in 1980. We are very close to eradicate polio. Polio have been eradicated or eliminated in many countries all over the world. There are only 2 countries that are still left behind. And because of the disabilities in these countries, the unstable situation. And after these countries will eliminate all the cases of polio, the whole world will declare that it will be free of polio, and then we can stop the polio vaccination. Similarly, for smallpox vaccination, that it was stopped and it was taken out from the immunization schedule. And I will speak about that, how can vaccine enter the immunization schedule and how the vaccine will exit the immunization schedule. I will give an example about that later on. Again, this is another example, and here there is a comparison between the communicable diseases and non-communicable disease, and you can see that before 90s, that communicable disease, the graph demonstrates the importance of vaccine and high vaccination coverage. The trajectory of the disease is declining rapidly, illustrating the power of vaccination within communities. And you can see that communicable disease have been declining gradually. And this is, by the way, in fact, vaccine played a great role, but there is another factors also that we have to be frank to talk about it, which is that hygiene, our hygiene is better, sanitation and water supply, automobility, plus also the discovery of antibiotics and medicines in general. This all led that infectious disease will decrease gradually by years. And now, as you can see in the comparison too, it demonstrates the causes of death in 2000, from 2000 to 2019, and you can see that non-communicable disease are right now the leading cause of death in the whole world. And this is the data from WHO. And you can see that ischemic heart disease is the highest, and then stroke, and then chronic obstructive pulmonary disease, etc., etc. Still, we have some communicable disease. Still, we have some communicable disease, but the burden of that communicable disease, the burden of non-communicable disease is much higher right now compared to communicable disease. But the problem that you can see that it comes to one communicable disease, like the pandemic that we are living right now, and it can shift the whole death rate in the countries, and can lead the death compared to other non-communicable disease. And this is the danger of the communicable diseases, that yes, we control them by multiple factors, and specifically vaccination, but for a time, but we always have to be alert and have a good surveillance system to make sure that we are detecting all viruses. For example, we were expecting for a very long time to have pandemic influenza, but actually it came from totally another viruses, which is coronavirus, that we didn't expect that it can cause pandemic like this. We had the Middle East coronavirus, and it was discovered here in the Middle East, and we had some issue with it, and case of death, and mode of transmission for a very long time was not clear, but still it was a limited death. يعني, the case fatality rate was like 10%, but compare it was 37% in the start and gradually decrease. But compare it right now to the COVID-19, you can see that it's totally different. The spread was very fast, and for 1 year have been hijacked from the humanity and from everybody's life. 2020 was just a year that everybody was in lockdown, sitting at home, anticipating what's happening until lastly we had the COVID vaccines and our lives start to come back to normal. And this is, I think, if anybody doubting vaccine, he will just look at this experience that right now we are currently living, and he will definitely understand the importance of vaccines. This is again for 2019-20, and also it will show you how the shift, how the disease map shift from infectious disease to non-infectious disease. Okay, I think now I want to speak about something very important, which is the vaccine hesitancy. Actually, WHO has identified the vaccine hesitancy as a measure of the top public health problems or threats that we are facing. Individuals tend to be vaccine hesitant for enormous reasons, including personal and negative experience and misinformation regarding vaccine. Political and economical climates also can play a role. What is vaccine hesitancy? As I said, you can see here, this is the 10 public health threats that have been identified by WHO in 2019. There was air pollution and climate change, non-communicable diseases, the threat of global pandemic influenza. At that time, we didn't thought about COVID-19. Fragile and vulnerable setting, drought and conflict, antimicrobial resistant was one of the problems that have been highlighted as a threat for health, for global health. Ebola and high threatened pathogen, weak primary care health system, vaccine hesitancy, dengue, and HIV. So you can see that vaccine hesitancy is number 8, as it's stated by WHO as a big threat for the public health or global health. And by the way, vaccine hesitancy, this is something not new. It had been there. Even this, I found this picture in the 1802 for British statist James, which at that time there was Dr. Edward Jenner, which the first person that he detected that made milks. So there was made that they usually bring the milks from the cows, and they discovered that when they have the cow box, they will not get the smallpox. And from here, the idea of the smallpox came, smallpox vaccine. So he inoculated some of these plasters, the pustules that he can get from these ladies, and he injected his own son with this cow box. And he discovered that his son, after a while, he didn't got the smallpox, although he done a different exposure for him to get the smallpox. So at that time, when the cow box was given to human to prevent for smallpox, there was some journalists that draw this picture that you can see that cows are getting out from the heads and mouths of people that have been received the cow box inoculation to prevent for smallpox. So vaccine hesitancy, the point here, the vaccine hesitancy have been here for a very long time. So what is the definition of vaccine hesitancy? So it's a delay in acceptance or refusal of vaccine despite availability of vaccine service. This is straightforward. So you have the vaccination service. And when we say vaccination service, you have everything. And you have the setting, you have the accessibility, you have the vaccine itself, you have the cold chain, you have everything. Despite of having that, you refuse or delay the acceptance, this is called vaccine hesitancy. It has been reported in more than 90% of countries in the world. It's a complex, context-specific, vary across time, place, and vaccines. It's influenced by factors as complacency, convenience, and confidence. The determinants impacting vaccine hesitancy have been divided into, they call it 3 C's, which is the I showed you here, which is the confidence, complacency, and convenience. And for confidence, it's involved trust in the safety and efficacy of the vaccines themselves, and the health system that deliver this, that deliver the vaccine, and motivation of the policymaker who decided on the system that deliver the vaccine. Complacency refer to when the perceived risk of vaccines, vaccine preventable disease are low, and therefore vaccination is not deemed necessary as a preventive action. And lastly, vaccine convenience, it's a significant factor when physical availability, affordability, and accessibility affect uptake of the vaccine. This is one of the big studies, not big study, it's a study that actually played a great role in vaccine hesitancy and actually increased the vaccine hesitancy all over the world. This is the Wakefield study. Wakefield, he was a physician that he made a study, I think, in 1998, and he established a relationship. The study was only 12 children in that study, but he established a relationship between vaccines, between MMR and autism. And a big contributor to the vaccine hesitancy, it was a big contributor to the hesitancy in the 20th century. He published it in Lancet, and Wakefield described 12 children with developmental delay. 8 had autism with 1 month of receiving the MMR vaccine. This created a great fear in vaccine and vaccine provider and demonstrate the power of publication initially, which would then be seen in the power of the social media. Although this was in 1998, after that there was multiple studies came out and they couldn't found any relationship. And then after that, the Lancet withdrew that study. And in their withdrawal, they said that there was the study wasn't based on statistical data. There is no control group. There was a statistical bias, and it made a vague conclusion that statistically not valid. So in 1990, there was a study done for 500 children, and they found no connection. Again, in 2001, there was 10,000 children that have been studied, and also there wasn't any connection. In 2002, there was more than 500,000 children have been studied, and to see the relationship between the MMR and autism, and there is no connection found. Although all of this happened, and from that date until 2012, many studies came out, but still until now, when we mention MMR, some parents or some people in the community, they will talk about the relationship between MMR and autism. So it just here, I'm just showing you the publication, the power of publication, especially that it published in prestigious scientific journal like Lancet. And actually, until now, we are in 2021, still suffering from this publication in particular. So, consequence of vaccine hesitancy. Of course, now we have seen a lot of consequences. Ultimately, vaccine hesitancy causes lower immunization rates, of course, which cause outbreaks and deaths from vaccine preventable disease, which shouldn't be because we have the vaccine. Reminder to that, the global measles outbreak that happened, the cases have been doubled, 200%. In 2018, 2019, in USA alone, there was 704 reported cases, the highest since 1994. Also, we have a polio outbreak, as I stated before, that polio have been eradicated in many countries, but unfortunately, again, in Philippines in 2019, 2020, there was a polio outbreak. And for 19 years previously, polio have been eradicated in the country. This is all because people started not to take the polio vaccine. There was some cases of polio-induced paralysis. So some of the cases, so usually polio-induced paralysis usually happen 1 in a million case. And there's some cases happened, and from there, the public trust in the vaccine have been shaken. Although here you can see 1 in a million, it's the benefit outweighing the risk, but still this have impacted on that. But after that, the polio vaccine have been studied. It was the vaccine was compiled of 3 subtypes, 1, 2, 3, and they found that subtype 2 usually the one that associated with polio-induced paralysis, vaccine-induced paralysis. So that was out, and right now we have a bivalent oral polio vaccine, which have a less risk even from that 1 to million for vaccine-induced paralysis. Also, and whooping cough, and this is very interesting. I think in 1970 there was some cases of children that have received the pertussis vaccine, the wholesale pertussis vaccine, and that caused encephalitis. And this is from 1970s. People started. Also, the cases were very little, but people trust in vaccine have been declined. And in Japan, in particular, the vaccination dropped from 80% to 10%, resulted in 13,000 who got whooping cough, and 41 people died. But what happened next? So it was understood that the wholesale pertussis vaccine can have a complication like this, although the complication was also 1 in a million. Also, as I remember, I can't remember it very well. And from there, right now we have in our vaccination program acellular pertussis vaccine. We don't have the wholesale one, and you can see it in the DTAB vaccine or the DTAB vaccine. This is just a reminder again. We need to remind ourselves about the complication that can be having from vaccine preventable disease. And you can see here the corneal scarring that can happen with vitamin A deficiency when people can contract measles. Encephalitis also can happen as a complication of measles, plus pneumonia and diarrhea, and that can happen as a complication of measles. The role of social media. Of course, the social media played a great role in the vaccine hesitancy. Social media has changed how information is shared, both positively and negatively. Social media helped the sharing of knowledge and information, especially to the hard-reached communities. But in the same time, social media helps spread the disinformation much quicker without the need to validate information. And we had lots of examples during this pandemic how social media disinformation have been played with the COVID. The spread of the conspiracy theory surrounding COVID and Bill Gates, vaccine disinformation shared on social media, found even it affect even you can see some of the professionals that they are not aware very about the vaccination itself, start to speak in a not scientific way about the vaccination. Vaccinology is a science, and it needs specialized people to speak about it. Not everybody, a healthcare worker, can know exactly the component of the vaccine, the effectiveness of the vaccine, how the vaccine can be produced and developed. So that's why I think this is also play a great role in the misinformation and vaccine hesitancy. The role of the healthcare worker. Traditional healthcare worker acts as viable source to promote vaccine uptake. They are trusted by their communities to promote successful vaccination campaign and manage expectation. COVID vaccine has seen an increase in vaccine hesitancy among healthcare workers for the following reason. There was a lot of question about safety and efficacy, concern. Also preferred the physiological immunity, distrust in government and health organization, autonomy and personal freedom. The impact of healthcare worker vaccine hesitancy has far-reaching impact on the community and particular vulnerable patients. So when the healthcare worker is declining the vaccine, actually he's adding to the burden of the problem, and vulnerable people can die and go as a result of that. We have here a study in Qatar for 1,038 responded. So it found that 42.7 would accept the vaccine compared to 45.2 were hesitant, and we had 12.1 were resistant completely. And this study done in the early 2021. And then also in the same study, it's found that 76% stated that side effects of the vaccine were a concern, and also found out that the migrant worker that was the easier who resident in the tight to their employment status are more likely to receive the vaccine in the tight governmental employer policy. So summary of the vaccine hesitancy. So lack of confidence in vaccine, unknown the reason, lack of confidence in vaccine, unknown future effects, fear in short amount of time taken to produce the vaccine, fear of pharmaceutical companies, false media, and intentional spread of disinformation, conspiracy theory, in conjunction with the belief of alternative medicine and own health. And this have been addressed by Germany and Biller in their studies in 2021. Then I will speak very
wonderful.
Yeah,
sorry to interrupt you, Dr. Khalid. Wonderful, but I'd like to have some questions posted right now to you. Can you please tell us what would be the most effective approach taken by the Ministry of Public Health to tackle vaccine hesitancy?
For vaccine hesitancy, of course, we need a multi-component approach that usually we can use when tackling the vaccines. Vaccine hesitancy. So there was a multi-component intervention, and includes two or more different methods that we have been used even here in Qatar. And one of these methods is dialogue-based intervention, dialogue between those implementing the intervention and the target community. There was involvement of the religious and traditional leaders, social mobilization, social media intervention, mass media intervention, communication tool-based, and healthcare worker training. This is very important, that healthcare workers should be trained about the vaccine, how they will administer the vaccine, how they will preserve the vaccine, the cold chain of the vaccine. And also information-based for healthcare worker need to be updated. I think transparency is very important when you are dealing with vaccine hesitancy. You need to be transparent with your community. And actually, this is what happened with Ministry of Public Health. From the first days of the pandemic, all information have been putting out for the community, daily cases, how many cases tested per day, how many cases positive, how many cases admitted, how many cases in the hospital, how many cases admitted in the ICU, how many cases died in daily basis. Plus, when the vaccine came out, what kind of vaccine that we will bring, the messenger RNA vaccine introduction. And also reminder recall-based intervention, which we used in PHC, which is using a telephone call to the target population about the vaccine. There was a great social mobilization, and this is the process where engaged and motivate a wide range of partners and allies at the national and at the national level to raise awareness of and demand a particular development objective of people talking about the vaccine and let them take the right decision.
Thank you. Another question. Given the fact that people adore the freedom of speech and they use it over social media, should there be strict rules to monitor fake news that creates distrust in vaccines? For the sake of everyone, should there be strict rules on social media to ban anything that considered fake news?
Of course, I think this approach have been taken here by Minister of Public Health. So Minister of Public Health was reviewing all things posted in the social media, and they had a very robust communication with Ministry of Interior to make sure that any disinformation, firstly, they will come and talk about it, rebuttal it. Yeah, exactly. They have to any misinformation and with well-integrated multi-component strategies that promote and influence individual for future intervention. With the scientific basis, of course, everything with the science and with the evidence-based data that have been currently published. Yes.
Okay, now I would like to ask the audience. I assume all of you took the COVID vaccine. What concern did you have when you took your COVID vaccine? Were you hesitant or complacent, or you gladly accepted the vaccine? You could type your answers on a chat quickly, please.
Dr. Susu, while our participants are typing their answers, there is another question from the audience.
Yes.
There's another couple of questions. So the first one is from Dr. Lubna. So she said, some people think that the COVID vaccine was developed in a very short time, so there is less research compared to other vaccines. Do you think this is a valid concern that people have when they are vaccine hesitant? So maybe both of you can respond to that question.
Right. Do you mind if I go first, Dr. Khalid?
Please, Dr. Susu.
Okay. Actually, this is the easiest myth to bust about the COVID vaccine being developed in a speed of light. The fact that mRNA technology was existing before we have the COVID outbreak or pandemic. There were trials and still existing clinical trials on influenza, mRNA vaccine, on Zika virus, on rabies, on other infectious diseases, Ebola. But when we were hit with COVID, all resources were tailored towards producing COVID vaccine. Besides, when the first case was recorded, like in December in China, and it was declared as communicable disease, the Chinese government released the genome of the SARS-CoV-2 virus on January 15th. So just within a month of the identification of the outbreak, the sequence of the virus was released. And of course, when the genome sequence was released, a lot of scientists jumped on the wagon and thought this could be a huge resource to speed the development of diagnostics, of reagents, and vaccines, of course. There's also a lot of funding that came to the COVID vaccines from governments, from the WHO, and from philanthropists to support the process. So putting all these together, none of the vaccine development had shortcut in the COVID vaccines. It satisfied from A to Z all the phases of basic science discovery, immunogenicity, efficacy, and the 3 phases of clinical trials on a massive number of volunteers, 74,000 volunteers in phase 3 clinical trial between Moderna and Pfizer. There were no chance for a shortcut or jeopardizing the safety and the efficacy of the vaccine. But it was success to humanity that we managed, global community managed to produce a vaccine within a year time.
Yes. Just to add on what Dr. Susu was saying, firstly, as Dr. Susu stated, 73,000 participants in clinical trial. It never happened with any drug, not any drug or any vaccine before. It never happened. And by the way, the Food and Drug Administration, the FDA, has a well-outlined regulatory process that assure any licensed vaccine has gone through a rigorous process to assure that it's meet the standards of safety and efficacy before being released. All COVID vaccine candidates being studied in the US are in the process of completing, they are already finished the process of completing rigorous studies, and there wasn't any cross-comers. And what have been described by Dr. Susu right now, that there have been significantly shorting in the production process. The US government and other government have decided to fund the production of the leading vaccine candidates. And this have shortened the time too much. And I will show you in my next slides how vaccine usually take very much time. And this is mainly because of the fund and because of the clinical trials and how to access to people, willingness of people to participate. All of these factors will take the vaccine for a very long time. And I think this there is a revolution right now happened with the messenger RNA vaccine, and I think the future of vaccine will rely on messenger RNA vaccine in the future. We are just waiting for more safety study, and I think right now we're all in a big clinical trial. Yeah, and right now we're living in a big clinical trial. So how many millions in Qatar by itself? We nearly used 4.6 million vaccines have been used in Qatar. In a country with 2.7 million. And other countries have been million vaccines. So if there is anything related to vaccine, at least in short term, it will be appear. When also WHO, when also FDA have been questioned about the long-term side effects. So most of the vaccine, usually the long-term side effects will appear within 2 months. Right now we are in the 8th month since the beginning of this vaccination campaign, or 9 months. And if there is any long-term side effects or anything that happened with the vaccine concern, especially the current vaccine that we are running, it will appear by now. And it shouldn't be not appear by now. Especially that right now we're giving the 3rd dose even. I just 4 days ago, I took my 3rd dose of messenger RNA vaccine as a healthcare worker, which is high risk, as was stated by Qatar government Minister of Public Health.
Wonderful. Dr. Khalid, for the sake of time, we still have 2 sections to go through pretty quickly. If you please proceed.
So these are the vaccines that here approved in Qatar. We have the Moderna vaccine approved for 18 years and above. It's messenger RNA vaccine. Efficacy is 94.1 efficacy, and it may need booster dose. We have also AstraZeneca. It's adenovirus vaccine. It's a viral vector vaccine with efficacy 60% from death, and more than that. I think 60% efficacy and 70 to 80% from death and severe diseases. And we have also the Pfizer vaccine, and which the only vaccine right now approved for 12 years and older. And I saw yesterday that Pfizer have published a new study that there is a promising remarks from their clinical trial that right now run from 5 to 12 years old, which give the vaccine the clinical trial. So soon enough, inshallah, maybe we can extend the vaccine to this age group. Also, we have Johnson & Johnson, and this is a single dose vaccine, and we have Sinopharm vaccine that have been approved here in the state of Qatar. So vaccine safety is measured in several ways. Before vaccine license for public use, the vaccine are tested for safety, efficacy, and all of that. We spoke about it. Authorization for emergency vaccine if medicine is needed to address the emergency once it's been shown to be safe. And by the way, right now, Pfizer vaccine is fully approved. It's not an emergency authorization. It's a fully approved vaccine by FDA. This means that it finished all the processes, and I think other vaccine will follow soon. So here are the vaccine development. So firstly, it will be pharmaceutical quality, and then non-clinical research, and then human pharmacology study, phase 1, and then therapeutic exploratory study in phase 2, and then clinical efficacy and safety study, which is the phase 3. And after that, all the documents should be submitted to scientific evaluation authorization committee like FDA and EUA and etc. And then the vaccine can be used in the large scale population, but still surveillance need to be there, monitoring of all the side effects of the vaccine, and then more studies of authorization and more study for the vaccine. So these all steps that have been here, as I said, the production of the vaccine have been getting have been shortened to make sure that we will have a faster vaccine during this pandemic. Here you can see other vaccines, the production of vaccines. So innovation, vaccine of innovation. You can see vaccine like typhoid. It took nearly many years that first link with the disease, and then identify it, and then identify the pathogen, and then the vaccine was licensed in 1980. Meningitis, and then you will see that the vaccine start to shorten. We understand more about the vaccine. We have more studies. The production of the vaccine start to shorting until you can see even for the measles, and then for hepatitis, Ebola. It's a little bit difficult, but for for the SARS in the same year. So beginning of the year 2020, by the end of the year, the vaccine was there. And this is, as I said, because of the speeding of the production process due to the funding that have been provided during that. I was speaking to a prominent professor of immunology, and he was talking to me. I was talking to him that messenger RNA vaccine is a new science. He said to me, no, it has been there in our labs for the last 15 years. We have been working with it, but it's a very expensive. We couldn't have enough money to show it and to make more studies. The pandemic helped us to have all these funds and accelerate the process. Here, I just put the powerfulness of the COVID vaccine. And this is just last week cases. And you can see in September 12th, we had 133 for the whole country. And then the cases gradually decrease until September 18. We have only 82 confirmed COVID in the country compared to the 1,000 of cases that we had in the early beginning in the second phase and the second wave and first wave.
So
right now,
Khalid,
yes.
do you think that we achieved herd immunity effect for COVID vaccine in Qatar?
According to this data, I can say yes, we have some sort of herd immunity. Now, 80% of Qatar population have received the 2 doses of vaccine. This is 80%. From the start of the pandemic until now, we had 234 positive cases nationally, and we have 604 deaths during this 2 years of the pandemic. And right now, seeing that we don't have this, you can see the whole week we don't have 0 deaths, and the week before we didn't have 0 deaths.
Excellent.
And the number is decreasing gradually of infected persons. This will show you that definitely we have some sort of herd immunity. Especially, don't forget that the vaccine, still we have to, there is a large proportion of the community which is the below 12, they are not vaccinated. Which we are seeing that the spread of the infection among them is more. And also, right now we start to vaccinate 18 to 12. I think we reached like 64% from that age group. I think by increasing that age group, we will see more and more reducing the number of cases.
Excellent. We have one question from Majid Thiyab. The question is asking why the COVID vaccine is given intramuscularly and not given intranasally or orally, since it's a respiratory disease. Well, the simple and short answer for the question, you give intranasally and orally live attenuated vaccines. And with COVID, with SARS-CoV-2, there is no live attenuated virus. That's not a choice. It's only killed or the mRNA or the spike protein itself. The second answer, the second reason why, because when you vaccinate intranasally or orally, it goes through the mucosal system, the mucosal surfaces. The clearance of the vaccine antigen would be much faster before it goes properly to the antigen presenting cells. Whereas when you go to the skin, you would have a localized site of inoculation where the sampling of antigen by antigen presenting cells would be maximized and would produce more beneficial. So the reason given intramuscularly, because it's inactivated, of course, and because it will be cleared very fast if given oral through the intestinal acidity and through the mucus cilia, etc., will not achieve a target. You need a live attenuated virus to induce mucosal immunity. All right. I have just a quick question to the audience. Since you presented the COVID vaccines, dear audience, do you think pregnant women should get the COVID vaccine? You could type your answers, please. Is it safe to give COVID vaccines to pregnant women? Any answers?
So the majority are saying that it is safe.
Yes.
Muhammad says probably not, but everybody else says yes.
Yes, it is safe. Actually, they did the clinical trials and they assessed the safety, and it's pretty safe. One more question to the audience. Do you think the mRNA vaccine technology would facilitate the integration into the human DNA genome or not? Any answers? Probably not. There isn't any single evidence so far, solid evidence, that this fragile mRNA vaccine could integrate into the DNA, because this mRNA does not have a helicase or integrase that would help it integrate into the DNA. Just a script of mRNA that will be translated through the ribosomes to a protein, which is the spike protein of the virus. So far, no evidence that it integrates in the human genome. All right. Now we'll come to the last part of the presentation, and Dr. Khalid, it's all yours.
Thank you very much. So right now, I just want to describe, talk generally about the Qatar immunization program. I think we explained this, but I will just go through it again very quickly, how vaccine will work with the immunity and eradication, elimination. So in this pre-vaccine, you will have the disease in high numbers. The incidence of disease will be high. Then there will be the vaccine cover. You start the coverage of the vaccine, then the disease start to decline. And then whenever there is a loss of confidence in the community, decrease the coverage, then outbreak will start. And then the resumption of the confidence will be again there. And it will go gradually until elimination, until eradication. Once the disease is eradicated, then for certain years, then you can take the vaccine out of your schedule. This can show you the 5 stages of eradication of any disease. In the same time, monitoring of the adverse reaction is very important in the middle, so it will run with your immunization program. The integrity of the immunization program depends on the surveillance and reporting of adverse reaction from immunization. This is very important. All countries should make sure that they have vaccine adverse event reporting system. This is very important, because this usually would keep the integrity of your program and making sure that you are controlling and you know everything that's happening and you can respond to any rumors that happen in the country. So these are the vaccines that have been in Qatar. We have the polio and yellow fever in have been introduced in 1997, 1979. Measles vaccine 1983. And look, measles vaccine was introduced in 1983, but until now, we just last year reached the elimination of measles in Qatar. Still, and we have 0 cases, but hopefully that this year also will have the same, and we will see. But I'm just saying that this kind of thing that usually happen. And of course, influenza vaccine is it's an annual vaccine that each year, according to the respiratory panel and virus circulated in Qatar space, then we will understand which of influenza vaccine that need for this year, either the southern strain or northern strain, depend on the influenza A and B component. So these are the vaccine in the immunization schedule. What is the governance of vaccine in Qatar? So usually, as you all know, that the Minister of Public Health usually provide the vaccine update, usually do campaigns, as we done a supplementary campaign like 3 years ago for measles, and by now we reach the cases are less by measles, and also producing the national immunization schedule for children, for adults, for pediatric, for adults, and also for defaulters, which will come through again there. But how the ministry take all these decisions? So the ministry have a consultancy a committee called INTAG, which is National Immunization Technical Advisory Group, and usually this INTAG it contain many consultants. It will contain pediatricians, senior pediatrician consultant, senior microbiologist, also senior immunologist, senior infectious disease consultant, senior microbiology, I said microbiology consultant. So all these consultants will sit there. Also public health, multiple public health consultants will be there. They will sit and they will understand, they will get their data from the FDA, local epidemiological data, European data, WHO, CDC, pharmaceutical companies, GCC policies, and other data that GCC will have. All this information will be given to INTAC, so INTAC can take a framed decision about which vaccine, which also, of course, with collaboration with WHO, which vaccine should be included in the immunization schedule according to the endemicity of the disease and what currently infectious disease that we have inside the country. So this is here the governance. The INTAC, actually, it's just a consultancy body. They will not enforce anything. They will give the information to ministry. Ministry will enforce the decision that have been taken by INTAC. Vaccine consideration, what we are looking for vaccine safety, we are looking for maximum more response and minimizing the adverse event as much as possible. And that's why we have to be aware about the type of the vaccine, correct storage, correct disposal, specific precautions and contraindication, correct site, correct technique, correct dose, minimum dose interval, correct age, intervention with other vaccination and medication. All of that need to be known very well. So any doctor need to deal with immunization and need to deliver vaccine. He need to be aware of all these elements so he can increase the immune response and minimize the adverse events. Here, this was each year, the Ministry of Public Health in April, they are celebrating the WHO Immunization Week, and this was one of our celebration. This is before the COVID, of course. And you can see here that Sheikh Mohammed bin Hamad Al-Thani, he is the director of Public Health Department in Ministry of Public Health, which under his leadership will be the vaccination program. And also you can see in this picture on your right hand side, Dr. Suhail Bayachi is the head of the vaccination program in Qatar. And in that celebration, Dr. Mohammed was announcing that we have reached 90 to 95% vaccine coverage in Qatar, and this is a very good achievement for the infectious disease in Qatar. This is here the pediatric national immunization schedule. All you can see in dark blue, this is a mandatory vaccine. So if you are a child below 5 and you want to enter school in Qatar, these vaccine you have to take all these vaccine in blue. Hepatitis A was mandatory a couple of years ago, but our epidemiological data that we have in the country and all the situation in the country, now the vaccine have been only recommended for children and adolescents with a frequent travel to high-risk areas. So now no longer. When I spoke before that when the vaccine can enter the schedule and when vaccine can exit the schedule, actually through the INTAC, these decisions have been taken. That according to the epidemiological data that we have in the country, according to what's happening in the coverage of the vaccine, then they will decide that this vaccine can be mandatory, this vaccine will be recommended, this vaccine we will no longer we need it in our immunization schedule, etc., etc., etc. This is here the adult immunization schedule, and this is all recommended vaccine. It's not a mandatory vaccine. Influenza, TDAB, varicella, MMR, meningococcal vaccine, hepatitis A if you are traveling, hepatitis B for special professions, hepatitis O also will be for people dealing with food handlers and like that. Also, they have to receive it. Hepatitis B, of course, for our healthcare workers that they have blood and body fluid exposure. Typhoid, yellow fever, anti-rabies. Anybody had a pre-exposure or post-exposure for any cat or dog, or that he think that it can contain rabies. And this is here our defaulter schedule. As you know, here in Qatar, that people living here are coming from all over the world. And all over the world, we have different immunization schedule to make sure that we continue to have the good coverage in the community and to not spread the infectious diseases. Any defaulter or anybody come to the country, they will assess his vaccination status, and if he's combining all the vaccine that we saw in the first immunization schedule, so that's it, nothing needed. If not, he will be, according to this the defaulted schedule, he will be followed by this of these schedules. The Ministry of Public Health have defined the defaulter, anybody that he missed his vaccination date, the scheduled vaccination date for more than 1 month. So if you have a vaccine at 4 months, but until the 5th month of age you didn't come, then you will straight away will be shifted from the normal immunization schedule to the defaulter schedule. And it made it very easy for physicians. They will just follow the age, and upon it they can give the vaccines with the time frame for the defaulter child. Now I will speak about adverse event following immunization. So the National Immunization Guideline 2017 have defined that adverse event following immunization, this is any medical incident that take place after an immunization that cause concern and is believed to be caused by immunization. So this is the definition that it is in our National Immunization Guideline, and you can find this National Immunization Guideline in the Ministry of Public Health website, where you can go through this guideline. Ministry of Public Health have established a surveillance program to detect and report and monitor all adverse reaction following any immunization. And usually the report of these cases, so it will be any sign or any symptoms or any lab findings or any disease discovered after a person received vaccination. So this is the adverse reaction. So they are classified to 3. They are classified to mild, moderate, and severe. So the Ministry of Public Health is requesting to report the moderate and severe. The mild one, where they don't need to report it because they are common, and usually it will be a pain in the site of the injection or low-grade fever. All these things not need to be reported. But if it is more than that, temperature more than 38, or a patient develop allergy reaction, or develop anaphylactic shock, or need to be hospitalized, all these cases need to be reported. Once these cases are reported, we have a committee that they will follow all these cases, and they will dig down more to try to establish if there was a relationship between the vaccine that have been taken and the outcome that right now the patient is suffering from. And actually, alhamdulillah, until now we couldn't, during this pandemic, there wasn't any establishment of any adverse reaction following immunization, especially COVID. We had lots of adverse reaction. We had lots of people, they have a pain in their site of the injection, they have a fever, some of them they had, we had, I think we had 2 anaphylactic shock that happened, that have been reported. This is what I remember for adverse reaction for immunization. In PHC, we recorded during the whole COVID vaccination program, we reported only 58 adverse events for immunization. So why we are monitoring the adverse event for immunization? As I said, in different countries, we have different immunization schedule. We have also different vaccine. I mean, even the patch-related problem. You can find that you will have PCG vaccine produced in Japan, and you have another PCG vaccine from Italy. So if you don't monitor your patch, if you don't monitor these different vaccines, you will not understand where this vaccine coming from. So I have to accelerate a little bit. I have only 1 minute. So this is a minor and major vaccine reaction. And I just put it there. So this is the minor reaction, and this is the major reaction, which is usually very rare. As I said, fever above 38, injection site abscess, cellulitis, required hospitalization. This is all major. This is our form to report adverse reaction for immunization that usually physicians fill whenever they encounter this. Immunization safety, as I said, immunization safety is the process to ensure monitoring the safety of all aspects of immunization, including vaccine quality, adverse event, vaccine storage, handling vaccines, vaccine administration, disposal and discharge, and waste management. About vaccine ethics, I think this is a thing that need to be all the time in the mind, because it's always about personal choice versus the greater public good. And also there was some concern about ethics in vaccination and testing and research. Who should be involved there, and what is the aspects of it. Informed consent is always needed. Access vaccine itself. As you all know right now, that 35% or to 40% of the production of the COVID vaccine have been only utilized in 10 countries compared to the rest of the world. So this is also an ethical dilemma, because without it, nobody's safe until everybody's safe. We know that, because if the virus is still spreading in other countries, it will reach to some sort of mutation that it can create another pandemic. I will skip this. Lastly, about travel clinic, this is the service that we provide in primary care. So provide service for traveler who seek CDC assistance to address their health-related need, mandatory requirements like vaccination or common prophylaxis. Usually the clinic also authority to provide international certificate like a yellow certificate, yellow vaccination card certificate, and prophylaxis in case you are like anti-malarial drugs and all of that. Everybody target, it's in all majority of primary healthcare services. And thank you very much.
Thank you very much, Dr. Khalid Al-Awad. We truly appreciate your very informative session. Because of the time, we won't be able to ask you many questions, but if there's any pressing question from the audience to Dr. Khalid, please write it down. We'd be happy to answer your questions. And I have questions.
We do have some questions, Dr. Susu.
Yeah.
Can I put the questions to you now?
Yes, please.
So the first question is, and we've touched on this already, because the government here in Qatar, we had a very robust approach to tackle vaccine hesitancy. So the question is, why don't all governments have similar policies to tackle vaccine hesitancy? And maybe Dr. Khalid, would you like to answer that question?
It's difficult. Each government is different and how they deal with their nation. You know, maybe here in Qatar, it's a small population. People tend to rely on their government. They trust the government. That's why it was much easier to tackle it, and there was a transparency all over the world compared to other countries, free world countries, where they have you will face that people persist with their personal choice, and they don't want to take this vaccine, or they don't want to give the vaccine for their children. So it's different from country to countries, but usually tackling them by multi-component intervention is the best way to solve the vaccine hesitancy. Dr. Susu, you can continue if you want.
Yeah, I just would like to add, in some other countries, the vaccine hesitancy being politicized, like there's political polarization around this issue, like the government cannot impose vaccines and the other side fight back and say it's for the protection of goods. So in the United States, this is the current situation. The vaccine acceptance has been affected by the ideology of some that they refuse the vaccine period, or because it's been a political issue being debated very heavily in terms of the politics in the United States between the Republicans and the Democrats. That created and eroded actually the confidence in vaccine uptake among those who believe in certain beliefs, which not helping the United States to control the pandemic. So President Biden just recently decided that all the United States federal employee who works for the government and the contractors, they must receive the COVID vaccine and show their vaccination. So he made it mandatory, and that of course created a huge political debate, like, in a free world, you do not mandate vaccines. But when you are facing a pandemic that's very difficult to control, what should you do? Leave it to the public to continue spreading the disease, or put strict measures forward to help curb the spread of the disease?
Thank you, Dr. Susu. I think we can have a session in itself on vaccine hesitancy.
Yeah.
We do have 4 or 5 other questions, so if I can just ask the panelists just to try to keep the answers quite short.
Sure.
So I think this question's for you, Dr. Susu. Could you elaborate on the relationship between vaccines and autoimmunity, please?
Right. there isn't any well-documented evidence so far that vaccine itself could induce autoimmunity. However, it has been reported with some capsular polysaccharides vaccines, very rare cases of Guillain-Barré syndrome. And the thought may be that there is a mimic epitopes in these sugar linkages that may induce some autoimmunity, but the incidence of Guillain-Barré syndrome post-vaccination is extremely low, and there isn't enough evidence or statistics to support the association between the two. All right, so so far it's not established. Now the question is out there for the COVID vaccines, would they induce autoimmunity? We've been using them for the past 8 months, 9 months. It has not been reported. However, as Dr. Khalid mentioned, right now the whole world is going through phase 4 of evaluating the vaccine, i.e. the public are vaccinated, and we monitor over the coming 3 years the long-term side effects, if there is any autoimmunity or not. But so far, no evidence.
Thank you very much, Dr. Susu.
Welcome.
And a question from Mohammed. I think this question is for you, Dr. Khalid. Once Qatar reaches 100% vaccine coverage, will the vaccine, the COVID-19 vaccine, continue to be available?
Actually, firstly, we'll never reach 100, because if you understand the concept of herd immunity, you will always find somebody in the community that you cannot give him the vaccine for a different reason. So 100 will never reach it. But still, for the vaccine continuity, for the current vaccination program for COVID, it will depend on our much study that are coming more about the antibody duration. Until now, we know from CDC and other literature that have been published that the level of antibodies can be there for the 8-9 months, and that's why Qatar right now decided that anybody that he have been 8 months from, no, not everybody, I mean the high-risk group, that they have been 8 months from their second dose, that they can receive the third. And actually, this is why, as I said before, that I just received it 4 days ago. Because it was noticed that there is a decline, there will be a decline after the 8 months for the antibodies. Now, the question will be, is the COVID vaccine will be with us like influenza vaccine? This is still, we don't know. As I said, any time will come to tell us, but right now we know that each year we are vaccinated for influenza vaccine, and here I will take this opportunity and encourage everybody, especially high-risk group, children below 5, pregnant women, elderly above 50, people with comorbidity, healthcare worker, to receive their influenza vaccination. There is no contradiction to receive the both of the vaccine together. Both of them inactivated messenger RNA or the inactivated influenza vaccine, and you can even take them in the same session, one in the right hand, one in the left hand. So there is no contraindication to take both of the vaccine together. Thank you.
Thank you, Dr. Khalid. And our final question from Ala. Do you think that following our experiences with the COVID-19 pandemic, there may be an impact on the community, a positive impact on the community? So, for example, that we see reduced vaccine hesitancies with other infectious diseases.
Wallahi, I hope so. We all hope so. I think this pandemic, it put us all in the spotlight. We have been prisoners for the last 2 years in our houses. We are missing our loved ones. Nobody can travel, and people have to realize that when it comes to pandemics, and the only way that we are coming back to normal is vaccination. What is different right now? Anybody who have hesitant with vaccine, I'm telling him what is different right now. We're still doing people have done the social distancing, wearing our mask, we are doing the hand hygiene, but still the cases didn't go down. The only way, when the intervention came with the vaccination, we can see that the cases came down, and we see the better response. And upon that, we see the easing of restriction, and people gradually right now coming back to their lives.
And one last point to add, the current data globally shows that those who receive the vaccine are well likely to be very protected against the infection. Even if they catch the infection, it will not send them to the hospital, whereas the severe COVID has been seen among unvaccinated. So the data on the ground supports that COVID vaccines are working and helping in controlling the disease. But it has to come with vaccine coverage, like with including at least 80% of the population to be covered with the vaccine to control the spread. The last 3 minutes, yes, the questions. All right, audience, you may read the questions and already the answers are showing.
Oh, sorry.
It's okay. So pretend that you didn't see the answer, everyone. Try to type your answers. What do you think? Read the statement and
So what refers to the protection offered to everyone in the community by high vaccination rates? Is it infection? Is it herd immunity, community immunity, or both A and B, or both B and C? So we have a mix of answers. Some participants are saying B and C, some are saying A, some are saying B. So would you like to tell us the right answer?
it is B and C. Herd immunity is equivalent to community immunity. It's interchangeable term. All right.
Okay, so a 4-year-old developed a pain due to swollen salivary glands on both sides of his face. He also complained of pain while chewing or swallowing. He was diagnosed with mumps. His parents asked for the vaccine, but the doctor explained that he does not need the vaccine. Which type of immune response is induced by this infection?
Come on, students, you know that.
So we have passive immunity, non-specific immunity, lifelong immunity, short-term immunity, or IgE-mediated immunity. So it looks like the majority of our participants are saying C.
Which is correct. Mumps virus induces lifelong immunity. So whether you get the infection as a primary infection, you'll get lifelong immunity, or get the vaccine with booster, you'll also get long-term protection. Correct. Third question, please.
So we have a 53-year-old visited his doctor for the annual physical examination. The doctor recommended the seasonal inactivated influenza vaccine. What is the best route of administration of this vaccine? Is it intranasal, interperitoneal, intramuscular, intravenous, or subcutaneous?
What do you think? C, intramuscular?
Yeah, we have some participants saying A as well, but majority saying C.
Correct. The correct answer is C, intramuscular. Actually, the intranasal influenza vaccine is usually the live attenuated. As I said, the killed vaccines would be cleared very quickly before they manage to induce a protective immune response. But if it's weak attenuated virus, it will induce mucosal immunity by just replicating a few times in whether the nasopharynx or in the oral, in the gastrointestinal tract in the case of polio. So with the inactivated vaccines, it's the intramuscular, correct. Fourth question, please.
So conjugated vaccines are composed of the following. So which of these is the correct answer? Conjugated vaccines. We have participants telling us that the correct answer is E, polysaccharides linked to a protein carrier. I think everyone is saying E.
Exactly. And that's the concept of conjugating the sugars because they are poor immunogens to a protein carrier because proteins are strong immunogens. So they would induce proper adaptive immune responses, that is T or thymus dependent that will create memory cells and long-term antibody response as well. Good. Fifth question and last question.
Okay, so we have a six-month-old boy. He's brought to the clinic for immunization. The prevalent vaccine that he will receive is composed
the pentavalent, sorry.
Oh, sorry, the pentavalent vaccine that he will receive is composed of what? So you can see the schedule on the screen in front of you. So you need to identify which of the vaccines the 6-month-old should receive. So we have a couple of answers so far saying B.
Yes. Yes, correct. The schedule is self-explanatory and the content are explained in the legend beneath. So when we talk about Penta, we're talking about 5 different vaccines combined together. That's Penta. Whereas Hexa, when you have 6 different vaccines, and of course Tetra, you have 3 different vaccines. All right, very well. Thank you.
Okay, well done. I think everybody's really well with those questions. So
yes, yes.
Everybody's paying attention today. Well done, everybody.
So you have a great students.
Yeah, we do. Actually, we feel very proud of them. Thank you, Dr. Khalid. Thank you, Dr. Zakaria. Thank you, our brilliant audience, for being with us tonight. It was a pleasure spending the evening learning about vaccines and how they confer protection to our community. With that, we'd like to end the session and say to everyone, good night.
Thank you for having us. Good night.
Yes, and my thanks as well for Dr. Susu and Dr. Khalid. Thank you very much for an engaging presentation.
Thank you, Dr. Zakaria. Thank you.
Good night, everyone.
Good night. To collect your evaluations, then you can follow the link that I've posted in the chat box. For those students attending, we will be emailing those certificates to you. Thank you, everybody. Good night.